Now, going along to the course, sometimes what happens is that the error is there in the OPD itself. We are busy surgeons, we have big OPDs, long queues, and the error has already happened before the patient had entered the OT. So, we actually missed in our OPD. These are some of the insights that I'm going to share what mistakes I did in last couple of years and would share a few of my cases here. It was a straight cut case of a female who came for surgery in the left eye with an immature cataract. The slit lamp examination showed a grade 2 cataract, fundus was normal, and IOL power was 24.5. Straight cut patient had a great multifocal done elsewhere in the other eye and wanted a similar multifocal here also. All was set and the surgery was done. Great centration, good surgery done. I was happy. 1 week, nothing was seen. After a week, patient comes 618 vision, not improving. What went wrong? It was a quiet eye, no inflammation, nothing. Mood was upset, and literally I pulled my hairs when I realized that I had no record of the other eye. Nothing I knew. The patient was happy. I was happy she came for the other eye to me, and I just did it. So was she amblyopic? Might have been. The power used was 24.5. No, even she had no records today, but she was sitting right here because this eye did not improve. That surgeon was good and I was bad surgeon. Hence proved. So the lesson learned was anyhow try to gain insight on what power of lens was used, what biometry was there, what refraction was there pre-operatively, see the glasses, do anything but try to know the status of other eye before you operate the second eye, if you have not done especially. Now in winters in north we are worshipped, we are busy, people are in queue. The case scenario was everything was set by an optometrist. Patient was presented before me on slit lamp, face down on slit lamp, well set, fully dilated pupil. All readings were normal, and yes, I decided to have a premium IOL, reasonably good, a bit large size rexis, good surgery done. Post operatively again 618. I don't know why 618 is after my life. And now literally my mouth was wide open when I saw this lady. She had a deviated eye, and even her husband denied that the eye is deviated. And this picture was taken for the husband to show. See, she has a squint. This was never seen either by patient, nor the husband, nor anybody, nor myself pre-operatively. So one has to undergo cataract surgery to find out squint. Dr. Siddharth. So, anyways, see the patient on torchlight before you take up the patient for cataract surgery. Many findings can be gained there. Now these kind of patients, especially after COVID, great surgery, great vision, 6/6, but unhappy. Why? Sitting in OPD every third day talking to all other patients also that I have so many problems. My eyes are watery. I keep rubbing my eyes. I have been given so many drops, 2 hourly drops. She had a hard cataract. Some keratitis was there. I also pumped prednisolone. That aggravated the dry eye again. And she has been uncomfortable and uncomfortable. See the staining, see the meibomian glands. I never managed it beforehand, but ideally, if you have a dry eye, meibomian gland dysfunction, never be in a hurry to have the patient getting operated. Try to treat it first, maybe a week or two, keep postponing for some reasons, and then take up the patient for surgery. Mature cataract can give surprises. A Morganian cataract, IOP was 20, mature cataract, other eye also had cataract, 660 vision. Patient wanted this eye first. I made sure there is no subluxation, there is no pseudo exfoliation. I had the B scan also done. I was wiser. Okay, fine. But then it was dilemmatic whether should I do a SICS and get rid of it or should I do a phaco. Patient paid me more. I committed myself for phaco. I did phaco. Now, as the pupil came down, I saw this monster. From where this came, she had a YAG PI. I never saw that. And then post-op vision was bound to be finger counting 2 meters. I knew it then and there what's going to happen the next month. And then this was the disc as expected. So she was on 20 pressure. She never disclosed that she has been putting these drops. She had a mature cataract. I had a normal B scan. I did a good phaco, and see how bad a surgeon I am. So I'm labeled not to give good vision. A Pandora box came. See this child. He has something brown. You can see with that cataract on cornea. He sustained some trauma with a wooden stick or something. Very uncooperative, crying, running here and there. So wooden stick injury was in the history. She was very uncooperative. A total cataract was there. I did an indirect, could get a good glow, but the disc was just barely visible. I was sure that there is no RD or a vitreous hemorrhage out there. No point sedating him, getting a B scan done, and quickly he was just booked for surgery. And it was an easy phaco to be done, a lens aspiration, and that was attempted. Now, peroperatively, this is a picture peroperatively. There was a hole in iris. Was it an entry wound? Something there? I don't know. All this was going in the back of my mind. I was operating, and then another hole, a PC tear. Was it a pre-existing one, or I did it then and there? I don't know. But there was a rent. Yes, there was a rent. There was a hole in the iris. Something brown was there in the cornea. But now it was all no point discussing. You have to complete the surgery. So, no, I will put the IOL in the bag. I kept it in the bag with this rent. And then, yes, it was done nicely. Patient vision was 660. Attendants were again howling and shouting and blaming and everything, what all they knew. And see this. There is a foreign body just near the macula. And my retina colleague also pulled my collar. Why did you place this IOL? Now from where will I get it out? But at that time I committed IOL. So I have put it. So these are the mistakes which we do. And yes, should have investigated more, but then this is done. And this Pandora box, I don't know what happened. They never came to me thereafter. Now, I had a retired scientist. IIPR Institute is there in Kanpur. A retired scientist came for me for surgery. 636 vision, a good juicy cataract. I was very happy, smiling and grinning like this. But then post-operatively 612 only. Not improving. Again, same scenario. I literally missed a small patchy kind of ERM and a pseudomacular. This is the OCT picture. This I missed in presence of a PSC. What crime I have done? But I missed it. He did not improve beyond 612. And you know, I got a letter from the advocate demanding 19 lakh rupees compensation. People are literally ruthless. We are sympathetic. Sample drop bhi le lo, ye bhi le lo, wo bhi le lo, but nobody spares us. So now the big question is, should we do an OCT for everybody getting cataract surgery done? Now people will say yes, but at least scientific answer is a careful retina examination is must. The maximum care which you can give. You can use your tools, you can use your eyes, you can have a microscope in your eye, anything. So it's good to learn from your mistakes, but it's better to learn from other people's mistakes. So that's the dictum today. Thank you. And for the next talk, I invite my senior, Dr. Manish Mahindra from Kanpur. He's a brilliant surgeon and internationally acclaimed speaker, and he's director of Khairabad Eye Hospital. And he would be giving insights on how a wrong choice of IOL can lead to an unhappy patient post-operatively, despite doing